to treat.
Thanks, Sanjay. Hi, everybody. Thank you, Peter and Sanjay, for the invitation to join. It's really been quite astonishing and exciting to see how relatively quickly, it probably doesn't feel quick to you all as you've been toiling away for a while, but to see PIRN become so well established and so productive in what seems like a relatively short amount of time has been really fantastic. And it's an honor to be invited to come and speak with you all. I'm going to start by providing the context in which this present study took place, because I think that's really important. And then I'll just talk about the study itself, how we approached it, what we found, and more importantly, how it's translating into ongoing work to address disparities. And then I'd like to briefly touch on the current state of the Sick Kids Health Equity data collection, because I think that both the American experience and our early experiences in Ontario have a lot of implications for what we might be able to accomplish together as a Canadian children's hospital group in this area. So starting with arguably the most important thing in everything which is context. The context is really quality improvement, and in quality improvement, where most everything we do is driven by this problem of the evidence to practice gap, which everybody's aware of this oft cited study that purported that the typical gap between evidence generation and when it is sort of scaled up to population level reliably is as much as 17 years. In quality, we often teach new learners and practitioners in quality to take on these individual projects, find a problem, solve it. And it's a great way to learn. But an increasing problem that we're facing is that this approach can contribute to something we call 1,000 flowers blooming, which is, a lot of little projects, many of which can be hard to get off the ground. And when they are successful, are often kind of dependent on an individual. And if that person, graduates or moves on to a different position, oftentimes the project sort of fizzles and isn't sustained. And so over my years in quality, I've gotten more and more interested in how can we really hitch ourselves to some larger efforts to try to get more done in a more sustainable way. And so the Learning Health Network is one approach to what I would call big QI. I think before we talk about learning health networks, I'll just go through quickly kind of a framework of different models for big QI. And I think that, the first one listed, multi-site QI research, is potentially something that you might argue PIRN is this or could be this. There's a initiative that Sanjay and I took part in a while back called IPASS, which was multi-site research and, arguably doesn't belong on a list of big QI, but because it was multi-site and because it, had a very sort of QI pragmatic design, it sort of lent itself to transition into broader dissemination. There's also a model which I call campaigns, and many of you will have heard of Choosing Wisely and Choosing Wisely Canada. The nature of this is that rather than espousing a specific best practice and having everyone collect data and submit data, it's more of a concept or an ethic that's promoted and that people sign on to. And they still mostly do, single center or local QI, but under that conceptual umbrella. The next model up in terms of, I think, the intensity of data is what I would call a comparative data sharing platform. And the best example that I've encountered in this space is the National Surgical Quality Initiative that's from the American College of Surgery, and they are surgeons, and they have a NSQIP pediatric, and many of our Canadian children's hospitals are participating. The idea here is that you submit data in, and it's very labor intensive data, like you have to hire a data abstractor. But with this very granular data, they can give you a risk adjusted report where you see where you compare, statistically significantly better or worse than your peer group. And so they don't tell you what to do. It just shines a light on where you have room for improvement. And then that drives local improvement, which at Sick Kids has been very effective in turning around some surgical quality problems that, weren't apparent until we had that data. The fourth thing on the list would be the classic QI collaborative. And all of you are familiar with this model, the sort of oldest, most embedded model in the pediatric space is probably in the neonatology space. So networks like the Vermont Oxford Network. And the hallmark of these is that there is a best practice that's, dictated from on high, and hospitals commit to collecting data and sort of submitting it back to the collaborative to sort of stimulate, shared learning and continuous improvement, like as a group. And then the last one is the one that, we would argue has the best or tightest maybe coupling between creating evidence and disseminating it, because it's sort of designed to do that in a continuous and seamless fashion rather than generating the evidence and then relying on the traditional dissemination and diffusion and knowledge translation strategies. So this is a set of examples of learning health networks that are all operated out of a common hub, but are all kind of North America wide of various sizes. Many of them are kind of disease specific or organ specific. So there's one working on inflammatory bowel disease, kidney disease, epilepsy, CF. The rheumatology collaborative is one that I know Sick Kids is very involved in. Our Ron Laxer helped to kind of found that one. And I think that there's Canadian hospitals participating also in some of these other ones. Solutions for Patient Safety is the one that I've been the most involved in. And this is a set of kind of just a sampling of results from these different learning health networks. Things like increasing remission in IBD patients, addressing preterm birth, transplant rejection, survival in severe cardiac disease. Some of the most interesting stuff is at the lower right-hand corner, which is from one of the newest networks, which is called All Children Thrive. And this is more local to the Cincinnati area, but they use the same methods of, co-production with families and rigorous QI to actually address some of the effects of poverty on kids. So reducing bed utilization for kids from the poorest neighborhoods, and even improving literacy as measured by third grade reading proficiency. So I think that's a pretty innovative and new thing for children's hospitals to be doing, and pretty inspiring. So Solutions for Patient Safety is one of the oldest and biggest ones of these learning health networks out of that specific group. And a common key ingredient in learning health networks is often there's a kind of a zealot or a small group of zealots who really have this, passionate, unwavering belief in doing something that is hard and is audacious. And they tend to be able to convince a lot of other people to jump on board. And that was certainly the case with the formation of this network. So this mission to eliminate harm across all the hospitals is something that has always been and continues to be taken very seriously by that group. They managed to convince a very large number of hospitals to sign on. We now have 9 Canadian children's hospitals involved, which is wonderful. And of course, at some point, some material resources have to come into play. It's not just the zealotry and the grassroots. In this case, there was a large federal grant on the US side as part of a big health policy initiative that provided some initial seed money, but it was able to transition to being totally member supported. So guiding principles of the learning health networks, a really important one is non-competition, which in the Canadian space maybe doesn't seem as important to call out, but in the US space where they have those horrendous US News and World Report rankings and things like that we thankfully don't have to contend with, people will find a way to use these things to compete for notoriety and things like that. And so it's super important to kind of try to eliminate that, because you want to avoid a sort of hub and spoke concept where it's like Boston and CHOP telling everyone what to do. Rather, this is, an all teach, all learn approach. And what's become really clear in my years with that group is that improvement is happening in every corner. And sometimes it's happening in the smaller hospitals, and no group or no hospital or no organization is like nailing it in everything. So, a small hospital might have solved a problem and they're going to help this other big hospital figure it out. And then conversely, the next time you turn around, the big hospital is trying to solve a problem, and or the other way around, the tables have turned. So it's truly an all teach, all learn. Another really important factor is that these operational definitions are agreed upon and they're enforced, in a very kind of hard and fast way, because we can't all be using different data. And so if you have to make a difficult choice to say, we don't all agree perfectly with this definition, but it's the best definition and we're all going to have to agree to it. That's super important, because this common data sets allows for continuous monitoring and transparency, which then of course allows this non-competition and this all teach, all learn. So it's not based on reputation, who's allowed to say what the best practice is. It's based on data and who's actually doing the best. Lastly, we're cognizant that although there's a huge amount of grassroots motivation, at the end of the day, for long-term sustainability, it's really important to have some senior leadership endorsement. And so the network really partners quite assertively and directly with the executives in the network. So I mentioned this idea of evidence generation purposefully translating directly to spread and scale. And so this framework is just the way in which this network happens to kind of depict that. And this was published along with the analytic strategies that I won't go in depth into, but the basic idea here is that all 140 hospitals can't be testing everything all the time. So if a new improvement opportunity comes up, it's volunteers who step forward and say, we think we have the capacity and the motivation to do this testing. And they'll test either a new potentially best practice, or a lot of times what they're actually testing is whether getting more reliable to an already established best practice will translate into better outcomes. And so, we're not striving for perfect, RCT level data, but we are striving for a level of rigor that says that this is compelling enough that it should then be scaled up to the whole network. And so these silly terms like pioneer and aviator and orbiting are just the names that the network gives to those different phases. So when something's aviator, for example, it's sort of, this is evidence-based and we should all be doing it, and all are kind of required to do it. At the lower end is sort of when if something hits kind of a plateau or a steady state, we don't want to continue to invest the same amount of resource and attention on that, because we want to be taking on new projects, new initiatives, new harm areas. And so things get sort of demoted a little bit to where we don't stop paying attention, because then you get drift and you fail to sustain, but you apply kind of just enough attention to keep sustainability going. So I won't get into all the results of the network. I love talking about it, but I want to get into the equity stuff specifically. But, the network has really eliminated a lot of harm, just as measured by the baseline rates of these harms before joining compared to the rates now. We kind of keep a running number, and it's recently passed the 25,000 mark, which is great, because these are very costly, burdensome. They're associated with a very long increased length of stay. And that's why it was a policy initiative. It was actually designed to reduce spending initially. But right when things were hitting this sort of peak of recognition with all this success, this is what happened. Somebody approached the leadership and asked whether the leadership was confident that their work wasn't making disparities worse, which was really felt or experienced initially as kind of shocking and insulting. How can someone say that all this work to improve harm actually be making disparities worse? That's preposterous. And typically, when people are very defensive about something, it's because they know they have a problem. And so thankfully, very quickly, it sort of turned around to, what? If we're honest with ourselves, we actually have no idea whether this work is making disparities worse, and we better look into it. And there was a brief moment of, feeling insecure because the quality and safety people didn't feel like they were experts in health equity, and equity is the most neglected domain of quality. So there was a little bit of insecurity, but very quickly, like immediately after putting out word that we wanted to do work in this space, tons of experts and passionate advocates just emerged and were ready to help. And there was like virtually no delay. And so that's what sort of gave rise to the study that I was invited to speak to, which is the FAIR study, which stands for Patient Harm in Relation to Equity. this is a little timeline that, we didn't jump right into the study. First, we had to sort of gather ourselves and get, a cohort of involved hospitals going. One of the first things that the experts told us was that although virtually every hospital, at least on the American side, was collecting health equity data because they have this mandate to do so, based on the shared payer, Center for Medicare Services, for any patients that are Medicaid, which in the pediatric space is like half or more of the patients. That despite the fact that everyone had to collect data, no one had any idea who was doing what with the data or how high quality or low quality the data were. So they were super excited to use this established network to do a big survey study to find out. And so we got about 100 hospitals to respond, and it was more or less all over the place, response rates as high as 95% and as low as 40%. And some hospitals actually using the data to address disparities, but many hospitals not. And so in pretty short order, we were able to kind of say, okay, well, here's our baseline, let's improve this. And let's get a cohort going. And like with everything the network has done, it was sort of a volunteer group of more ready people that stepped forward to form the cohort. And so this was the publication that arose from that, the FAIR publication, and what I'll get into the details of now. So I love those what is known and what does this add statements. So I've kind of paraphrased it here just to kind of get right to the upshot before I get into the details. Of course, we all know that healthcare disparities are well described in multiple settings and to some extent in pediatrics. But a big problem or barrier to addressing it is that the data collection systems are very variable, and there's kind of a barrier to doing this collaborative type of improvement like we've seen in other domains of quality. And so the main thing that this study added wasn't to show yet again that we have disparities, although that's important. It was that it lays out a novel approach to aggregating data across disparate data sets. And I think that's really important for us, because if they think they have disparate data sets, I mean, we have this loose aggregation of 10 or 13 different health systems, that some of which have a mandate and some of which don't. And so we can probably anticipate that we would have a lot of variability in our data sets as well. So I think that that's relevant to us. When we put out the word to inspire people to volunteer for the cohort, only 32 stepped forward. So 32 is a lot in terms of, that's quite a lot of data and powerful, but actually not when you look at the whole 148. I guess it suggests that only a minority of hospitals felt in any way ready to start doing QI in the space. They had to get commitment from their CEO to provide the resources to submit stratified data for the top 2 harm types or harm areas in the network, which are central line associated bloodstream infections and unplanned extubations. And so once we had those 32 who volunteered, and they didn't have to prove that their data were good. It was just if they were willing, they could sign on. We got busy kind of exploring the quality of the data, the feasibility of doing stratified data, and the hospitals that were further along were kind of teaching and coaching and mentoring the ones that were struggling. And, really collaboratively with everyone on the line, worked out what kind of an analytic strategy would we take, what would our inclusion and exclusion criteria be, what's going to be the comparison group, lots of really important decisions to make when you embark on an analysis like this, and it was done very collectively. Interestingly, although it was only a minority of hospitals that signed up, it wasn't just the big whale, CHOP and Boston hospitals, or Texas Children's, the one with 933 beds. Quite a few of the smaller hospitals, which are typically hospitals within systems, also signed on. So that was nice. And then also just geographically, there was like very even representation across the US. The data quality inclusion criteria were moderately stringent. And so not all 32 were able to make it in the final analysis, but 27 did. And here's just the logos of those. So you'll see a lot of familiar high profile names there, but you'll also see some of the smaller hospitals that you may not think about or hear about a lot. So one of the first tasks and the most arduous, unglamorous, unsatisfying but necessary tasks was this like figuring out what the range of data collection strategies there were, and then trying to wrestle them all into one common data set. And so it's, even though they're working off a common list because it's mandated to them, still people found ways to do this very differently. So for example, a simple thing like whether you allow people to choose multiple races or ethnicities, or whether you force them to just choose one, there was huge variation there. In the States, this huge issue, which we talk about a lot less in Canada, is Hispanic or Latino, Latina, Latinx a race, or is it an ethnicity? Huge topic, massive can of worms. I won't get into it here, but there was variation in how people handled that. And so we just, through lots and lots of discussion with a wide array of stakeholders, came up with a master list, and it meant that we had to just make some choices about lumping and splitting. And so it resulted in things like a combined category that had Hispanic, Latino, Latina, and multiracial Hispanic lumped into one group called combined Hispanic. And so there's just really obvious pros and cons in doing that. I mean, I think the spirit of this is that people should be able to self-identify exactly how they want to self-identify. And if that means there's 500 categories, then so be it. But if you're going to try to do stratified analysis, you're going to have to make some choices about what, how you're going to lump things together. And so that's something that, as we embark on the very early work in the Canadian space, is something that's constantly at front of mind for me. This, and I apologize for the low resolution. Don't worry about the numbers because I'll show them on the next slide, but I just wanted to give a flavor for the primary analytic tool that we use, which is funnel plot analysis. We use this a lot in our Pioneer analyses because it's a nice way of quickly seeing the huge range in sizes of, usually it's the different hospitals. And so seeing the standard deviations, whether it's 2 or 3, and how wide they are for the smaller groups or smaller hospitals, and how narrow they are and so forth. In this case, though, it wasn't hospitals that were plotted, it was the different ethnic groups. And so you can see that there are some groups which are much larger and some groups which are much smaller. So in the American space, for example, the American Indian or Alaska Native group was very small. And it does say Canada First Nations there, and that's because SPS is trying to be very inclusive and has included Canadian nomenclature. However, I don't want to confuse anyone, none of the Canadian hospitals were able to submit data to this, so there is not any Canadian data here. But what I'll show next is just the actual standard deviation information and sort of the number that not everyone was able to do both CLABSI and unplanned extubation. So we had 25 hospitals for CLABSI, but a smaller number, only 13 for unplanned extubation. But there were 2 groups in the CLABSI analysis that had 2 to 3 standard deviations higher rates of this harm outcome than the reference population, and 1 group which had 2 to 3 standard deviations lower than the reference population. And this, I came to learn, was a little bit of a different approach. A lot of the prior disparities work had used the white population as the reference group, and we were really encouraged not to center whiteness and instead to find a more appropriate reference group. So we used both the small cohorts average, the 32 hospital average, and we also did the analysis against the whole network average, and interestingly found very similar results using both of those reference groups. For the unplanned extubation, the result was a bit different. We did find 1 group with an even larger degree of disparity with higher harm outcomes, and the same group that had lower harm outcomes than the reference group, the white group. So, folks that work in this area were not surprised to find disparities, but there was a lot of gasping at just the magnitude of it being, even worse than we thought. And also just, the study's not designed to get into why these disparities exist, but there is a lot of evidence and expertise to inform that. And a lot of health problems are very multifactorial, and you can get into effects that take place out in the community that are in place long before a child comes to a children's hospital. But these are things that kids do not come into the hospital with at all. that they acquire in the hospital. So there should not be disparities. And these should be, and I think are, very, very actionable. So, at first I thought, oh, people aren't going to care about these harm areas for disparities. There's much bigger things like literacy and life expectancy and child mortality and all, and all that. But then over the time I've spent looking at this, I've thought, actually, no, this is where we should be starting, because no one can deny that these are related to the care that the kids are receiving while they're in the hospital. I'll address limitations before we go back to that why question. Again, it's an observational study. I mentioned the variability in data collection, which, we tried to mitigate, but is still kind of messy. We did have some hospitals that had pretty high proportions of missing data. We did a sensitivity analysis to see if that was likely to have impacted our findings, and determined that it hadn't, but it's a limitation. I mentioned the imperfect grouping of categories. And then it's possible that this volunteer sample of 32 hospitals doesn't represent the whole, American landscape. In terms of the why, we had kind of been preparing for people's first question to be, why would these exist? So we were creating this framework before launching the FAIR study for all of the different factors that go into a disparity, a safety disparity. And the ones that are kind of bolded are the ones that we would argue are in the control of a children's hospital. So whether it's interpersonal bias, whether it's systemic racism, things like, to give very practical examples, we think that we're being random when we decide which patients are going to have the practice audits, where the nurses are going to be observed, and are they doing the prevention strategy? Well, it turns out it's not random. And so for reasons we can't explain, but we can speculate on, certain populations that are at highest risks of harms are getting the lowest amount of observations, and other groups that have the lowest amount of harms are getting the highest amount of observations. Well, that's like immediately remediable. And that's been the primary way in which some of the hospitals have actually managed to eliminate the disparities. You can also imagine structural problems, like suppose you have a program in place to engage families in a prevention strategy that relies on the family member being at the bedside instead of at work. There's going to be some structural barriers there. So this framework has been useful. With that, maybe I'll move on to quickly the sick kids one, and then I'll be really eager to get your thoughts and feedback and hear what everybody's doing in this space, both in research, like the Patty-led application that was mentioned, and I'm sure lots of other initiatives as well. So this slide, it kind of illustrates what Ontario Health is saying they feel are the benefit of systematic health equity data collection and why they're mandating it. And it's not just the work, like I described, to just collect data that doesn't benefit the patient in the moment of care, but we can analyze later. It's meant to begin a respectful interaction with a patient and family by asking these important questions that sort of recognize their uniqueness and address their needs right away. It's meant to give point of care intervention. So language is the obvious one, but things like, not sending home a patient with a prescription they're not going to be able to afford to fill, or crutches they're not going to be able to pay for, and things like that. And then the work, like I've described, the more stratified analysis to look for and eliminate disparities, and also service planning. So there's 4 reasons why Ontario Health claims to be mandating for us all to do this. The Ontario Health Questionnaire is very long. I'll run through it quickly just to give, picture how hard it might be to just ask race, ethnicity, and language at the moment of care, and then picture this survey. So it's, what language are you most comfortable with? Were you born in Canada? If no, when did you arrive? Indigenous identity is called out separately rather than being lumped in with the other ethnicities. Then we get into ethnic background, then we get into race, then we get into disability. Could you benefit from support? Then we get into sex assigned at birth, gender identity, transgender identity, which is called out separately, sexual orientation, trouble paying for basic needs, income, and how many people does that income support. There's also 4 or 6 optional questions, which get into a little bit more granularity around the needs, the material needs, but picture the complexity of figuring out how are you going to ask a little kid about, like, how are you going to ask, say you want to talk to an adolescent and you want them to self-report on, say, their gender and pronouns and sexual identity. We've added pronouns to our sick kids list because we figured we can't ask gender and not ask pronouns. But you're going to keep it secret from the family, but you're going to make it available to providers, but you don't want the providers to unintentionally out the youth in case they don't want their family to know. And then you're going to ask the youth what their income is, but they don't know what their family's income is. It's complicated. So I just want to stress that as much as I see the American experience as inspiration that we can do this, what we're trying to do in Ontario is an order of magnitude, I think, more onerous and complicated, and hopefully more useful and more meaningful, but it's not trivial. The approach we're taking at Sick Kids is to recognize that there's many moments of care where you could do this, and there's multiple workflows. So you could ask a patient to self-report or a family to self-report, or you could ask a staff member to ask the questions and enter them into the health record. You could do this before the moment of care by sending someone an email and using a patient portal. You could do it at the moment of care while someone's waiting, or you could do it like really at the moment of care, integrated in, say, your history and physical. So we've articulated this into the form of 6 different workflows. And the one with the box around it, or the 2, is the only thing that we currently have live at Sick Kids, which is having a person with special training approach the patient and ask them. Takes about 8 minutes at minimum. And it's only live in our emergency department, and it's utilizing a group of research volunteers. So we're not at the point of having, say, a registration clerk asking these 13 questions of patients. We're about to go live in a couple weeks with the patient self-entry workflow, which has required building some stuff into our Epic and MyChart, which is our patient portal. That's really exciting. But our best clinic probably has maybe 40 or 50% of patients that are signed up for that. And it skews towards white, high education, high income English speaking. So it's a great way to get people filling it out, but it's not it's not a magic solution to the challenges of getting these data. So with that, I put down a couple of implications that came to mind for me in terms of our Canadian context. One thing I will say on the positive is that I've been in Canada long enough to remember a lot of talk about disparities being an American problem. Hopefully some of you are thinking, what? No one's saying that anymore, because people really aren't saying that anymore, but it wasn't that long ago when a lot of people were saying that. But on the challenging side, we'll have, as I mentioned, major heterogeneity of data collection, mostly in the space of zero data collection. And our population is different. And I think some of the American hospitals are able to have a lot more statistical power when they have 20% Black patients and 30% Hispanic patients. Populations of interest to us, like Indigenous populations in some of our centers, is going to be much smaller. And so it's going to be hard to have that statistical significance. Hopefully that won't stop us from, acting on disparities, because at the population level, if they exist, then likely they exist locally, but it's still going to be a challenge. So with that, I think I'll stop sharing and look forward to hearing folks' thoughts.
Great, thanks, Trey.